Thanks for sticking with us throughout the day. It's certainly a privilege to be back up here. I think I was invited back up both to give you a sense of what CDC and HHS more broadly are doing in the area, but then in part because CDC has a couple of very important things happening in the next few months. First, we're aiming in January to release prescribing guidelines, which I'll talk about in great detail. And as well, we just released some research priorities for the field in prescription drugs and heroin-related overdoses, so I will focus on that. So I want to now talk about CDC's public health approach to prevention, and I tipped some cards a little bit during the Q&A this morning about 3 of the signature initiatives that we have underway. First, I'm going to talk about standing up enhancements to get more complete and timely information on drug-related overdoses. Second, I'm going to talk about implementing the Prevention for States Cooperative Agreement Program, what it's all about, what it aims to do, and our goals overall. And then finally, developing the prescribing guidelines for primary care practitioners for the treatment of chronic pain outside of active cancer, palliative care, and end-of-life care. I'm going to also outline some of the prescription drug and heroin-related research priorities at the end. So to step back to sort of give you the satellite perspective, U.S. Health and Human Services Secretary Sylvia Burwell recently announced a targeted department-wide initiative aimed at reducing prescription opioid and heroin-related overdose deaths and dependence, and included 3 priority strategies, all of which you've heard about over the course of our time together during today. The first is providing training and educational resources to health professionals, including developing prescribing guidelines to assist providers in making informed prescribing decisions and to address any inappropriate use of opioids. Second, we just heard Dr. Coffin's great talk on increasing access and use of naloxone. And third, we've touched a little bit on medication-assisted treatment today, but not a ton. So expanding use of medication-assisted treatments such as buprenorphine and methadone in combination with counseling and other behavioral therapies to treat substance use disorders. So at CDC, we aim to complement the work that's happening within the other HHS operating divisions and to fulfill niches that are really right in CDC's wheelhouse. To do this, we are focused in on 3 specific areas. They are to improve data quality and track trends to monitor the epidemic, to strengthen state efforts by scaling up effective public health interventions, and finally to enhance patient safety by supplying healthcare providers with data, tools, and guidance for evidence-based decision-making. And I'm going to outline some of our highest priority work in each of these areas. So we are trying to improve the quality and timeliness of opioid surveillance data. Specifically, we're trying to generate more near real-time surveillance of ED visits related to drug overdoses and to improve surveillance of EMS transports related to drug overdoses, including the administration of naloxone. And to do this, we've worked with a few states, largely in the Northeast, to get better ED case definitions using text searches of ED chief complaints, triage notes, and discharge notes. And syndromic trends in a few of the pilot states closely paralleled those trends documented in ICD-9 CM codes and comprehensive ED discharge files, but of course are more real-time. And a part of this work I mentioned this morning is we've put together some standardized statistical code in SAS to assist states in implementing this new type of surveillance. And as I mentioned, we've done similar work with EMS to generate that code. Please feel free to reach out to me afterwards. I'll connect you with staff at CDC who's put this together. I'm happy to make those introductions. Of course, there are some inherent challenges with potential for misclassification and other sources of bias, but that said, this is meant really primarily to be a timely early warning of large increases or hopefully decreases in drug overdose mortality and to better target our prevention efforts. This September, we launched the Prevention for States Cooperative Agreement Program. It's really the culmination of years of work that we've done in states. It builds upon a pilot program that we put together called Prevention Boost that we launched in 5 states last year. And the Boost program really confirmed for us the necessity and capacity of states to implement proven evidence-based strategies within their borders. A total of 16 states were funded for 4 years with an average award of around $875,000 per year. And states were selected based on a number of evaluation criteria, but most notably, they were competitively chosen based upon a high drug overdose mortality rate and the capacity to act. As one of the clever staff that I have working for me said, we're really trying to meet states at the intersection of burden and readiness. So while states are required to implement some known effective strategies, and I'll talk more about what those are, the funding does give states the flexibility to tailor their prevention efforts. This is the logic model that's guiding the work of the Prevention for States program. It's a little too complicated to walk through step by step, but I did want you to see overall how we expect change to occur. And this came about over many, many months of iterations, working with Dr. Frieden, who's the CDC director. He is an extremely smart man. He's very demanding, and he's very impatient. And I mean those all as compliments. And he pushed us to put together this logic model, which in essence are the dominoes that need to fall for the change that we need to happen. It's the popcorn trail, if you will. So we believe that changes in programs and practices will lead to changes in provider and patient behavior, which ultimately will lead to changes in overdose death rates. And if after the talk you pull up this slide, you can read in greater detail about the specific interventions that we see that represent those dominoes, if you will. So we've structured the PFS program to advance two main goals: hone in on key high-impact data-driven activities that address the epidemic on multiple fronts, and to provide states with the flexibility needed to tailor their prevention program that fits the program in their state and reflects their judgment about how best to approach the work. There are 4 priority strategies in the Prevention for States program, 2 of which are required and 2 are optional. States are required to enhance and maximize prescription drug monitoring programs and to implement community or health systems and insurer interventions. This includes activities like moving towards universal PDMP registration and use. We had a good conversation earlier this afternoon. While we may disagree about what the sort of frequency of use needs to be, I think everybody believes that they need to be used more regularly. Having more real-time PDMP, where a prescription is almost instantly added into the prescription drug monitoring program once it's been filled. And in some states, the time lag could be as long as a month. States like Oklahoma have moved to near real time. So obviously, if you're a prescriber and the delay is a month or more in your state, it's really not a great clinical tool. If a doctor shopper comes to you, it comes to your practice and the data is a month late. So expanding proactive reporting to target high-risk, inappropriate prescribing, and to link PDMP data with health outcome data. And we saw from Dr. Prusnick's presentation how important and effective that can be. An example of a health system intervention might include something like strengthening a state's PRR, or Patient Review and Restriction Program. This is when high-risk patients are limited to one doctor and one pharmacy for their opioid scripts. And while not required, states can also advance policy evaluations. So, for example, evaluating a pill mill law or a Good Samaritan law or other policy or regulatory changes. And finally, there are these, what we're calling rapid response projects. This gives the state a flexibility on a year-over-year basis to redirect and target a hotspot area or issue. So as we talked about a couple of times, and I mentioned this morning in my presentation, the fentanyl issue would be something that we would want a state to target when it crops up in their state as an issue. We're in the process of developing opioid prescribing guidelines for primary care providers, as I mentioned, for chronic pain outside of active cancer, palliative, and end-of-life care. We believe that guidelines are needed to better align opioid prescribing practices in primary care settings, which, as you saw this morning, can vary widely across the country, with the best available evidence to ensure safe, effective pain management. The guidelines will outline strategies for safe and effective use of opioids when evidence demonstrates their benefits outweigh their risks. And I do want to mention, because it's come up a lot as we were in the process of putting these guidelines together, that these guidelines are non-regulatory and do not represent a standard of care. Rather, they give providers recommendations that can inform their prescribing decisions. All the while, prescribers will have ample room to use their clinical judgment and address each patient on a case-by-case basis. So the primary evidence informing the CDC guidelines comes from this AHRQ systematic review, which was released last September, and I mentioned it briefly this morning. This review rigorously addressed the effectiveness of long-term opioid therapy for outcomes related to pain, function, and quality of life, as well as the harms and adverse effects associated with opioids. And we updated this review with any new evidence that had come out over the previous 12 months. So we developed the guidelines using the GRADE, or a Grading Recommendations Assessment, Development, and Evaluation method. This approach specifies the systematic review of scientific evidence and offers a transparent approach to grading quality of evidence and studying the strength of recommendations. CDC is developing the guidelines using a rigorous and transparent four-step process, which has included a core expert group, a stakeholder review group, public engagement, and peer review. And I want to mention, I'll talk a little bit about what each of those entails because of the importance of the guidelines. So the core expert group, and several members of the core expert group are here with us today, provided input on recommendation statements drafted by CDC to be included in the prescribing guidelines. They met a couple of days in late June of this year. The CEG included a limited number of primary care professional society representatives, subject matter experts, state agency representatives, and we tried to select members of the core expert group in a way to minimize conflicts of interest, enhance objective assessment of the evidence, and to reduce scientific bias. A larger body, the stakeholder review group, includes 20-plus interested organizations that provided comments about the specificity, applicability, and implementability of the specific recommendations. And in this group, there is representation from professional organizations that represent specialties where opioids are most commonly prescribed. Next, we had a public engagement opportunity, a couple of days in September 17th and 18th, I believe, that allowed broader public input on the guidelines and gave us a chance to sort of get the general public involved in the review. And finally, the guidelines were sent to 3 peer reviewers, and we're in the process of going through formal internal review. To date, we've received over 1,200 unique comments and made 350 substantive changes to the guidelines, recommendations, or supporting text. So it's been a huge undertaking. Ideally, the goal is to have these guidelines released in mid-January of 2016. And we'll, of course, need your help with dissemination. That's one of the reasons I'm here talking with you. So the guidelines are still in clearance, so I'm a little bit limited with what I can share, but I will say that they address determining when to initiate or continue opioids for chronic pain, opioid selection, dosage, duration, follow-up, and discontinuation, and assessing risks and addressing harms of opioid use. Really, the core of the guideline is a reevaluation of what we've been told about opioids for chronic pain in light of what we now know. It's not radical, it's a common sense approach to prescribing that updates how we should use opioids for chronic pain in light of their uncertain benefits, but increasingly the known and serious risks, and we've heard about these serious risks over the course of the day. So at the broadest level, there are 3 take-home messages that when you see the guidelines, they will jump off the page to you. They are that non-opioid therapy should be preferred for chronic pain outside of end-of-life care, and that when opioids are used, the lowest possible effective dose should be prescribed to reduce risks of opioid use disorders and overdose, and providers should always exercise caution when prescribing opioids and monitor patients regularly using prescription drug monitoring programs and other means. So let me close this truncated talk by talking about some research priorities. As I mentioned, CDC recently, we had a research agenda that went from 2009 to 2018, and when the new Injury Center Director, Dr. Deborah Oury, took the reins, she said, you know what, we really need and that, by the way, that research agenda said nothing about prescription opioids, so obviously that needed to change. So she came in and said, I want an agenda that's practical, implementable, and then can set some research priorities for us that we need to address in the next 2 to 5 years. So, and they cut across 4 specific areas, and they're outlined in the next 4 slides. So public and private insurance programs and pharmacy benefit managers can play a key role in improving opioid prescribing. Program administrators can develop algorithms to analyze claims data and review physician prescribing and patient use patterns. These reviews could identify high-risk prescriptions, and insurance and benefit managers can also improve drug formularies or preferred drug lists to discourage unsafe and ineffective prescribing practices. It's unknown how effective these strategies are when applied to prescription opioids and in what ways they improve prescribing behaviors and patient outcomes. And of course, there's also the question of what strategies are most cost-effective. We've heard throughout the course of the day that states are enacting policies and strategies aiming at curbing the epidemic. This includes some focused on facilitating PDMP use. As I mentioned, making more real-time, mandating their use, and proactively using data to flag high-risk patients and prescribers. the reality is we actually don't know how effective some of these programs and policies are. So at present, there really is limited evidence to show which of these policies and strategies are most effective, and cost savings are important considerations for states to consider too. Understanding the risk and protective factors that drive opioid misuse, abuse, and overdose is really critical for developing effective prevention strategies. Epidemiological investigations identified both individual characteristics, and you heard about them earlier today, like gender, age, income, and mental health, and prescribing characteristics like high dose and extended duration use as risk factors for prescription opioid abuse and overdose. However, we have yet to learn the full constellation of factors that drive the overdose epidemic or protect patients at risk. Research also suggests that a large proportion of people currently using heroin have a history of prescription opioid misuse, and that recent increases in heroin use and overdose might be driven by people using prescription opioids beginning to co-use heroin, and Dr. Coffin mentioned that in his last talk. It's important to use and triangulate surveillance data, such as data from PDMPs, coroners, medical examiners, and law enforcement to identify which factors place individuals at high risk for prescription opioid misuse and overdose, and in turn, heroin use and overdose. And we have an RFA on the street right now to encourage this research. And finally, the majority of patients receive opioid analgesic prescriptions, as you know, from their primary care providers. And I hope I've convinced you that inappropriate opioid prescribing is one of the key drivers of the prescription overdose epidemic that we're in the midst of. And we believe that clinical guidelines and coordinated care plans, such as those that Dr. Van Korf and Group Health have implemented, could assist health systems in improving the quality of prescribing practices and, importantly, to improve patient safety. However, essential to the improvement is understanding how these practices are best adopted, such as through easy-to-use clinical algorithms, training modules, electronic clinical decision support tools, technical packages. Technical packages is sort of a Tom Frieden term for what are the suite of interventions that if ported from one environment to another and implemented with fidelity could have the same outcomes. And of course, outreach to professional and medical societies and health systems that are all critically important. So which works best to change clinical practice? All of these things are unanswered questions for us, and we want to seed and support research in each of these areas. So thank you very much. I look forward to the discussion that follows. Thanks.